Hi, everyone. It is Blood Clot Awareness Month, as you know, and tonight is very exciting. Our PEP Talk is Ask the Expert, and we have my PEP partner, Todd Robertson, here with us tonight. And backed by popular demand is Dr. Sam Berkman. As many of you know, Dr. Berkman is a member of the National Blood Clot Alliance Medical and Scientific Advisory Board, and he has been for a long time. Thank you for that. He is also a clinical professor of medicine in the Division of Hematology at UCLA since 1991. He is a graduate of Tufts Medical School in Massachusetts, completed his hematology fellowship at UCLA and his medical oncology training at the National Institutes of Health. He is board certified in internal medicine, hematology, and medical oncology. Welcome, Dr. Berkman. We're so delighted to have you back tonight.
Thank you. Thank you.
Great. Okay, so we have a few housekeeping items before we get started. First, as a reminder, we are here to provide educational content only, and we are not giving specific medical advice. Every patient is unique, and you should speak to your own healthcare provider. Todd and I talk about our blood clot situation all the time. We do not give each other medical advice because we know that each one of us is different, and we speak to our own individual doctors. So please do the same. We have a few housekeeping things. We're going to have a poll, which Todd will be taking over shortly. We always want to learn from all of you and improve our pep talk. So you're going to see some poll questions shortly. And also, there should be a slide here for the 100,000 challenge. I'm not sure if that's coming up or not. But we have our 100,000, let me see, I think. Shazam, there it is. Great. So March is Blood Clot Awareness Month. As you know, we have our signature 100,000 Reasons Challenge. This is a 31-day virtual challenge where we ask people to run, ride, walk, etc., in remembrance of the 100,000 lives that are lost each year due to blood clots. And so we would love all of you to participate, join a team, start a team. But we would love to have all of you involved as much as possible. We're honoring the 100,000 lives lost, and we're looking to raise $100,000 to support the NBCA programs. Okay, with that, we are going to turn it over for the poll questions. And I'm going to turn it to you, Todd.
Thank you very much, Sam. Thanks for being here. It was an honor to meet you in Washington, D.C. That was a great time to meet you. That was there was a lot of energy. And thank you so much for being here. We're going to go ahead and read off some poll questions, and a lot of you patients have had to do this before. For those of you who have not, please just participate and choose one of these answers because we like hearing from you and we like to collect this data. First question, how did you hear about the NBCA? Was it an online search, my doctor or nurse, family or friend or other? If you are a patient, how long after your diagnosis did you learn about the NBCA? While still in the hospital, 0 to 4 weeks out, 1 to 3 months after discharge, 3 to 6 months after discharge, 12 plus months after discharge, not available. And I got to scroll down myself. If you are a patient, how long ago was your blood clot? 0 to 3 months, 3 to 6 months, 6 to 12 months, or 12 months plus, or not available. So if you could answer those real quick. We're going to get into what I think is going to be a very fun pep talk, because I think you can learn a lot in a short amount of time, Leslie, when you're able to ask a lot of questions, and these patients have a lot of questions. And we may not be able to get to everybody, but we're certainly going to give it a try.
We're going to try. And while we're waiting for responses, if you do have questions, please put them in the Q&A. And then the chat function will be for information pertaining to things that are going on with NBCA, or if you want to say hi, where you're from, etc. But please put your questions into the Q&A so that we can see them and have Sam answer them. Okay.
All right, we're just going to go through this real quick. A lot of folks listening and not viewing, so we want to read these out too. How did you hear about the NBCA? 58% through an online search. That's exactly how I found the NBCA long ago. My doctor or nurse, 0%, family or friends, 7%, other, 35%. If you are a patient, how long after your diagnosis did you learn about the NBCA? 3% while still in the hospital, 35% 0 to 4 weeks out, 1 to 3 months out was 21%, and then 3% at 3 to 6 months out. Also 25% for a year out, and 13% not available. And the third question, if you are a patient, how long ago was your blood clot? 38% 0 to 3 months, 9% 3 to 6 months, 18% 6 to 12 months. Did I not get to the last one because my screen went out? But that's what I had.
No, I think you got to everything. So
Okay.
a lot of new
Okay.
people joining us tonight. This is really important information.
It is.
Okay. All right. You ready? We're off. I'm going to jump in first with one of the hundreds of questions that we have received from people. So can you please talk to us about how can one prevent clot recurrence beyond medication and compression socks?
So, well, first of all, if the clot is provoked, you're probably not going to get it again if you unless you get in the same type of situation. You might, but that's one way. The treatment would be with anticoagulation and with local measures. And the other thing is, you want to take the appropriate precautions in high-risk situations. In other words, if you're going to go to surgery in the future, you need your doctor to know that because you've got a history of a blood clot now, so they need to give you prophylaxis. If you're going to go on air travel and you're no longer on anticoagulation and it's over 4 hours, you want to take maybe a baby aspirin or maybe a 2.5 of Eliquis. If you're going to take an automobile ride, you want to stop after an hour and 15 minutes and kick the tires for 10 minutes. If you take a blow to the leg and it doesn't seem to be getting better immediately, then you might want to check out with your doctor. So what I would say, in addition to those things, is if you get into high-risk situations, take precautions.
And Sam, just to be clear, so compression socks don't prevent recurrence.
No, they don't. They're just an adjunct. They're an adjunct, and they're recommended. They are recommended by the American Society of Hematology for people who are going on air travel and want to do something. They're recommended over aspirin and over a low dose of anticoagulation. But I personally give people like an aspirin or a low dose. But if they would prefer taking compression hose for that. But no, they don't. They're not a treatment for blood clots, and they're not something you would use in a high-risk situation as a standalone measure.
Okay. Todd?
Hey, so while we're on the subject of travel, and I hear this a lot, I get to see the question a lot in the support group, these things pop up right when someone's planning a trip, they'll suffer a DVT, and then a week goes by, and then they wonder about traveling. What about traveling with the blood clot actually still present? It hasn't absorbed, hasn't dissolved yet. As far as they know, they still have it. Are there any recommendations? Should they not travel? What's your advice on that?
Okay, so it depends on the situation. If they just got this clot a week ago and they got a big swollen leg and it hurts them to get around the airport and they need a wheelchair and the travel is elective, then I would tell them not to go. Now,
Right.
If you get someone who had a clot 6 weeks ago, and they're on anticoagulation and they're back to their previous level and it's an important trip, I think the anticoagulation will prevent them from getting a clot during the air travel. So I can't give you a blanket answer for every situation. You've got to individualize it, but I certainly wouldn't take someone who had the clot a week ago and has a big swollen leg where it kills them to walk across the airport and tell them just to go travel.
Yep, absolutely. Leslie?
Okay. Are there dietary restrictions for individuals on blood thinners? And if so, why? And if you're on a DOAC, what about if you're on a different dose? So by that, I assume they mean if somebody's on 10 milligrams versus 20.
Okay, so these are two separate things. First of all, with Coumadin, yes, you've got to keep the amount of green vegetables constant because it's got vitamin K in it. So it doesn't mean you can't have salads. You can have plenty of salads, but you just got to keep it constant. Otherwise, you'll get a lot of variability. Now, the other question you asked me has to do with DOACs, and it's really rivaroxaban that you're talking about. Rivaroxaban comes in 10 milligrams, 15 milligrams, 20 milligrams, and 2.5 milligrams. And it's completely absorbed in the stomach, unlike all the other anticoagulants. So if you take the 10 milligrams, you don't need to take that with food because it will get absorbed. But if you take the 15 or the 20, there's too much medicine in there, so you have to take it with the largest meal of the day to slow down the passage through the stomach so it all gets absorbed. And when I've seen people get a blood clot on rivaroxaban, it's one of three things. It's either they're not taking it with food,
Hmm.
15 or the 20, they're non-compliant, or they're taking a drug which is an inducer of one of the enzymes, like P-glycoprotein. So what happens is, like, the most common ones would be the seizure drugs, Dilantin, Tegretol, Primidone. If you take those drugs, they increase the GI tract from, they make, in other words, the P-glycoprotein is an enzyme system in the GI tract, and it excretes, it takes the Xarelto and it pushes it out into the bowel movement. And when you give them an inducer, it does it to a greater degree. So if you're getting a person on that, that can make the drug very inefficient. So if you got a person with a seizure, you don't want them taking those drugs. You want them to take Keppra. Keppra is the drug a person should be taking if they're on Xarelto or Eliquis and they have seizure disorder, not Dilantin, not Tegretol, not Primidone.
Wow. Interesting. Okay. Well, that's really important to know. I think that needs to be in our frequently asked questions list that we have on our website for patients.
And that's the second time you've touched on that. The last time we were talking about Xarelto, because I'd been on it for 13 years, and you had pointed out that there is a problem with noncompliance, and because it does require that you take it a little bit differently than the other DOACs. So I'm glad you brought that up. It is a very important topic.
Well, there's actually more problem with noncompliance with the apixaban because it's a twice-a-day drug. So the fact is that it's not, I don't think there's any more noncompliance with the rivaroxaban. I just think there's a problem at times not taking the drug correctly with the 15 milligrams, 20 milligrams, taking it with the largest meal of the day.
Correct. Thanks, Sam. Okay. So just remember, some of these questions coming at you have come across blood clot support groups that I've seen over the last decade. And Sam, they don't let up, and we never get any really clear information, but I don't think there's any data on this. But here's one of them, just to kind of break up the flow. So you're going to hear some crazy, not crazy ones, but just kind of out of the blue. You don't hear it too often, but when you do, it makes you wonder. And so when new patients get on a DOAC or an anticoagulant, they experience a lot of different kinds of side effects. Some may experience some that no one else feels, but everybody feels these side effects. These feelings are real. Is there any data out there or any correlation at all to someone feeling colder? They get the chills more. They feel that there's a temperature change since they've started the blood thinner. Is there any relation there at all?
Okay, so these are very rare side effects, but you can never dismiss a side effect because every person's different. And so you got to discuss it with the patient. You got to say, how tolerable is this for you? Because it might go away. It might be something where it just involves the person getting used to the drug. So, but if it doesn't go away, and they really don't tolerate it well, then we have a wide armamentarium we can use. I mean, if they get this with Eliquis, we can use Xarelto, or we could use dabigatran, or we could even use Coumadin. So, I mean, it depends upon whether it's transient or whether it's continues, and just how intolerable it is to the patient.
Okay, thanks, Sam.
Okay, next up. Is there a genetic predisposition for blood clots? And what are the implications for treatment if you have a genetic predisposition?
So basically, you don't treat anybody just because they got a genetic predisposition. They have to have a blood clot for them to get treated. So I think what's important to know about a genetic predisposition is how is this information ascertained? In other words, did they have a family member that got a blood clot? Because people with a factor V Leiden mutation, which is the most widely known mutation, 95% of people with this will never get a clot. So the fact that they've got V Leiden mutation, maybe because they went to 23andMe or something and found that out, doesn't mean they need any prophylactic anticoagulation. If they have a family member who had a blood clot and they got screened and they have a V Leiden, then you know they're one of the 5%, that gene that's thrombosis. So actually, the fact that there's a family history is more important than the V Leiden, because with the family history, you know that whatever the person might have is thrombotic. So that's a more important piece of history, that they have a family history, not the V Leiden or the prothrombin 20210A, unless you're talking about a very young person who might have a protein C or protein S, and that would be something you might want to look at. But those are people who are going to get a clot before the age of 30 usually. So if you're talking about most people, having a family history is more important piece of information.
Good to know. Okay, thank you.
Okay, so a lot of patients need a little bit of help. I see some emotional distress when people talk about the hair loss when they start taking anticoagulants. Is there any relation there to the med? And is there anything that they can do? Who should they see? Is there anything that can help improve that and prevent some of that hair loss?
So I have heard about that. I've never had any patients with that particular problem, but I've certainly heard about it. And I would switch the drug because hair loss is something you can measure. You know, this isn't just something psychological or something that's subjective. This is actual hair loss. And I would check their thyroid, I would check their iron, and I would have them see a dermatologist, and I would consider changing them to a different anticoagulant.
What about emotional trauma causing hair loss?
Well, you know, DVT is a big source of emotional trauma to begin with. And of course, having, you know, if they're having a lot of upset about the hair loss, you want to talk to them and just how bad is this trauma? You might want to refer them to get some help with discussing it. But getting a DVT is a very traumatic event to the first place, because like I was talking about in Washington, you know, there's more deaths for venous thromboembolism than there is from traffic accidents, breast cancer, and HIV combined. And traffic accidents, HIV, and breast cancer are things people live in mortal fear of. Venous thromboembolism, they don't see it coming. So
Right.
when they get this situation and something they never even knew existed, wasn't even on their radar screen, it's extremely traumatic. And if I'm going to talk to a person when I go see them in the emergency room and talk to them about this, because they've been blindsided, I'm going to have a third person there, either a relative of theirs or a good friend, because the airways get blocked and they don't remember much of what I tell them. Because there's just so much anxiety in the system. So thromboembolism, and the other thing that happens is someone gets a pulmonary embolism or a DVT, and the next time they get pain in their leg or in their chest, they think they're having another one, even if they're anticoagulated. So that's something that we need to talk through with them so we don't subject them to all the radiation of another CT angiogram.
Right, right.
There's a lot of pervasive anxiety in dealing with this whole disease.
Yeah, there really is, and NBCA has great resources available. Todd always hands them out in the patient group, but we have a lot of resources on, you know, mental health, and this is very, very common. We don't want anybody to go through this alone. Majority of us have suffered from this. Myself, Todd, all of us have dealt with the PTSD really of having a blood clot.
Yeah, and I just want to say, because I noticed a couple of comments about not that came in while we were talking about that, saying, well, not everybody has someone. Sometimes we feel
Yeah.
much more alone because we don't have any family connection. And I just want to let everybody know, hey, I've been there. Everybody was dead long before me, and I was by myself, and it was rough, but you can make it through. And we're all survivors. So we're here listening to you, and we're glad you're here too. But everybody that goes through this these events, it's all very impactful. And like Sam was saying, the trauma, the emotional impact is huge, and we're all feeling it, and we've all been there. So those were just all great points, Sam.
Absolutely. And we have our support group, and it truly is a community and a family. So encourage everybody to stop on by. Our light is always on, as we say. Okay, we're going to take a question from the Q&A. This is actually a really great question. It's from an anonymous attendee. Are there any good blood thinner options for someone who struggles with severe anemia and cannot take iron supplements?
Well, that would have nothing to do with it. I mean, the problem, you see, is if you've got severe anemia and you bleed, you don't have as much of a safety net as someone who doesn't have anemia, because you're going to be bleeding starting from a lower level. That's the problem. It's not that you're at any greater risk to bleed because of the anemia. The anemia does not affect your clotting and make you more likely to bleed. In other words, when a person has a bleed on anticoagulation, anticoagulates do not cause bleeding. It's just if you have a hole someplace, it's going to bleed more on the anticoagulant. So the fact that you have anemia, if it's due to iron deficiency or B12 deficiency or something else. Now, as far as taking iron, if you can't take oral iron, you might be able to take intravenous iron. Intravenous iron, like Infed D, for example, which is low molecular weight dextran, is safe, quick, and cheap, and will replete your loss in a week or two versus 4 months with oral iron. And it doesn't cause side effects like constipation, indigestion, gastritis. So I would suggest if you've got anemia due to iron deficiency and you can't take the iron because it causes you gastritis, indigestion, constipation, whatever, get intravenous iron. And if you can't tolerate it, your insurance will pay for intravenous iron. It's just that your doctor has got to say that he tried oral iron first and it didn't work.
Okay, good to know. I didn't realize that with the intravenous, so that's a good thing to pass along to people.
Yeah.
All right. Mr. Robert?
Yeah, I'm going to grab it from you here. So I'm interested in this one too. This one came in from our viewers. My tests for factors causing clots were all negative, so I have been put on Eliquis for life. Is that safe? So long-term use for life, for decades, is it safe to be on this on the DOAC for that long?
Okay, so basically, it sounds like this person had what's called an unprovoked or idiopathic blood clot, and the risk of recurrence is about 5% per year. It's felt to be a chronic disease, and that you need protection for the rest of your life, because if you stop, you will have a 5% per year risk. And if you had a pulmonary embolism, most people with a pulmonary embolism will recur with a pulmonary embolism. Most people with a DVT will recur with a DVT. And each pulmonary embolism has a 10% fatality. So you really got to be protected if that's the case. Now, after several months, after 6 months, 8 months, if you don't have if this is an idiopathic DVT, you can have a conversation with your doctor about whether to go to half dose. If you're taking 20 of rivaroxaban, you go to 10. If you're taking 5 BID of Eliquis to 2.5. But it's got to be a really, in-depth conversation, because the risk of major bleeding on these drugs is about 3% per year. The risk of bleeding in the brain is under 1% per year. So you could talk to him about that, and express, and your feelings should be factored into the decision whether to drop you to half dose. You shouldn't make the decision yourself, but it should be factored in. And I think that whether you had a pulmonary embolism versus a deep venous thrombosis, and your feelings about this, you might want to get a D-dimer test to see if your clotting system is still activated. And if it is, I would stick with the full dose, I think. You might want to check an ultrasound to see whether the clot in the leg, if there was a clot in the leg, has resorbed or has become chronic. And men tend to have a higher risk of recurrence than women do. So all these factors need to be taken into consideration and with a conversation and make a decision whether you want to go to half dose. But basically, the risk of another clot is always going to be greater than a major bleed. And the major bleeds are usually not, they're like a 2-unit GI bleed or bleeding or something like that. They're not bleeding in the brain. Bleeding in the brain is less than 1%.
Why do men have just to follow up on what you were saying, why do men have a higher rate of recurrence?
Okay, so I don't know the answer. No one else knows the answer either. It's not due to testosterone. It's not due to a higher hematocrit from the testosterone, although if you get too high a hematocrit, it can increase your viscosity, but that's not the reason. It may be simply because they got longer legs. I don't know.
Yeah, taller.
That's the reason I've heard discussed the most. I had this conversation with Vic Tapson a while ago, this exact conversation, and neither of us knew that that's what kind of comes up, maybe it's because people have longer legs.
Well, but I'll tell you, as a guy back then, I had a doctor get in my face one time because I wasn't taking it seriously enough. I had this Superman attitude, right? Maybe I don't need to take that on time, or how serious can it be? It was like I didn't display my emotions. I didn't display any concern for the situation. Now that was 13 years ago, and I've learned a lot since then. But I think we guys sometimes have a hard time sharing things, and
Well,
the way we.
I think, if you get threatened by something and frightened, then, people are going to react very differently depending on the person. And some people are going to be terrified. Some people are going to deny it. Some people are going to get angry. Some are going to blame you, the doctor. I mean, you're going to get all kinds of reactions when people get really threatened by something like this. And you got to expect the whole run of the mill.
Yep. Yeah. Well, health anxiety counseling was the best thing I did, I think, after the blood clots. See this all the time in the group. People asking about, can they still visit their chiropractor for issues that they've had in the past? I've had a blood clot. It's been a month. Can I go to the chiropractor?
Yeah, great question. Great question. I'd be careful. Chiropractors are like anybody else. Some of them are better than others. And like anybody.
Yeah.
And they're cracking your neck there, and you don't want to get a carotid dissection. You don't want to get a clot in your jugular vein. If you have a predisposition to clotting, if you've already had a clot and you could clot, and someone takes your neck and subjects it to unusual stress, I would be very careful of that.
Okay. Hey, unusual stress. So Leslie, I'm going to give it back to you, but so piggyback onto another question I see pop out of the blue every once in a while. So I heard it wasn't good to ride on a roller coaster now that I'm on an anticoagulant, or now that I've had a blood clot. And I'm thinking neck snap. Is that a thing? Is that why some doctors say no on the roller coaster? Or have you heard anything like that?
Well, I know that scuba diving, you're not supposed to go down too low. So
Right.
I think it's kind of the same thing, rapid descents, rapid ascents can cause problems with. I've heard that more with Coumadin. I haven't heard that with the DOACs, but it's
Fair enough.
kind of like scuba diving.
Yeah, fair enough.
All
Leslie?
right, I think you got 3 questions here, so I'm going to take 2 just to even us out. Okay. How does clot size or the amount of clots affect the time necessary for them to dissolve?
Okay, clots the treatment we give is not designed to dissolve clots. In other words, the anticoagulation doesn't dissolve clots. It does two things. It prevents new clots from forming, and it prevents any clots that are there from traveling to distant sites. And the word we use is embolize. That to embolize means to travel to a distant site, and it's named by the site of its destination. So a clot that embolizes to the lungs is called a pulmonary embolism, and a clot from the heart that goes to the brain is called cerebral embolism. The question was, how long does it take for a clot to?
How does clot size affect dissolve time? Or
I
not?
don't think there's any data on that. And you'll get some people the clot's never going to go away. It's just going to become chronic and affixed to the wall and scarred down, and there's going to be no threat to anybody, as though it wasn't there anymore. And some clots are going to completely go away. And I think it's got more to do with the constituency of the clot than the size. So I don't think whether it goes away or not depends necessarily on the size alone. I think it's got to do with the amount of fibrin in the clot, the amount of platelets in the clot, the person's system of dissolving, like the thrombolytic system in the body. I think it's more a function of the person's clotting system than the size of the clot.
Okay. As a follow-up, if you have a history of clots and are factor V, should you avoid any vitamins or supplements, vitamin K, either alone or in a multivitamin?
So yes, I would avoid vitamin K. Yes, I've had patients who took too much vitamin K and have gotten clots just without factor V Leiden. So
Wow.
I would avoid vitamin K if you've got a factor V Leiden or something like that.
And what about just regular, like a multivitamin?
I think that's fine, but check the amount of vitamin K in there. But yeah, a multivitamin I think should be fine. Don't forget vitamin K is as a fat soluble vitamin, so you can get too much of that. Vitamins like B12 or folic acid or niacin, they are water soluble, so you can't get too much vitamin C.
Mhm.
But vitamin K is the one I would be concerned about.
Okay. Todd?
Oh, I thought you were going to take like 4 or 5 of those.
No, I said 2.
Oh, okay. All right. All right.
We're having a pep fight.
So I just suffered a DVT. I'm asking, this is an actual question. Suffered my first DVT. Are they going to give me another D dimer in a month to check and see if it's still there? And am I going to get a D dimer on a regular basis to make sure that I don't clot again?
Okay, so it's a good question. You're not going to get a D-dimer on a regular basis. No, there's 2 reasons to do a D-dimer. One is if someone comes to the emergency room and has signs and symptoms of a possible blood clot or pulmonary embolism, and you take what's called a Wells score, which is a score to see if they're at high risk, medium risk, or low risk. And basically, if they're at low risk, you might do a D-dimer, and if that's normal, you can save the person a CT pulmonary angiogram if it's for pulmonary embolism. So that's one reason to do a D-dimer. The other reason to do a D-dimer is if you've got a person who you've been treating for 6 months, 8 months, and you're making a decision about whether either to stop them or to put them on half dose, and you've gotten their opinion about what they like. You've checked whether they're a man or a woman. You've checked maybe see if the scan shows any persistent clot. And if you're still on the fence as to what to do, you might get a D-dimer. And if the D-dimer is abnormal, you're probably not going to want to take them off anticoagulation, or you might want to continue it. You never want to get a D-dimer in the hospital because almost everyone in the hospital is going to have a positive D-dimer. It's not a very specific test. So you're not going to be getting periodic D-dimers unless they are considering stopping or lowering your dose. And then if they need the information of a D-dimer to make that decision, they will do it. So those are the two indications to rule out the need for a CT angiogram or a duplex, or to make a decision about whether it's safe to stop your anticoagulation, but you're not going to get it to monitor the progress of your clot. You just take the anticoagulation, and you might get another duplex scan at a time down the road to see how you're doing, but you're not going to monitor it with frequent D-dimers.
Thank you, Sam.
Good to know. So Sam, we get a lot of question about what people refer to as natural blood thinners. And we had quite a few people write in about this, and I'm going to take one of the questions from the Q&A. Is cayenne pepper an option in replacement for a blood thinner for an active 50-year-old with a fresh saddle PE? I think that's question number one, but the broader question to you is natural thinners versus taking an actual blood thinner like a DOAC.
Okay, so what do you mean by a natural blood thinner? What do you mean? Can you give me an example?
So she references cayenne pepper,
Yeah, so
garlic, things of that nature.
never ever give cayenne pepper to somebody with a saddle pulmonary embolism. That person would be in the ICU and would be getting thrombolytic therapy or catheter-based retrieval of the clot, or a surgeon would come in to do a pulmonary thromboembolectomy. And cayenne pepper would be nowhere in the picture. Now, once you got them through that, if you did, because there's about a significant mortality to a saddle pulmonary embolism, maybe 30%. Once you got them through that, you would put them on a DOAC. You can't take a person with such a high risk situation and put them on a treatment that is not FDA approved for that treatment. That would be considered substandard care, and you would be subjecting yourself to a medical malpractice claim and possibly state medical licensing board action if you did something like that. You really, I'm not saying there aren't certain drugs that are not, I'm not saying that all drugs that are not FDA approved that are over the counter are bad drugs, but this is not the place to go using them. This would be viewed as definitely substandard care, malpractice, and I would steer clear of that.
Great response. I mean, Todd, you can comment on this also. We get this a lot, what folks refer to as natural thinners, and we really want people to take their medication to stay safe.
We do. I mean, you're right. It's the proven method. I mean, and each DOAC's got its look. If there was just one perfect one for everybody, I'm sure that would be great, but there's not. Sometimes you need to search around for yours. Warfarin wasn't for me. But once I found what I needed and when it worked for me, I mean, 13 years on Xarelto, this is a pretty good record. It's a pretty good track record. So
yeah,
it's really important that we take what we're prescribed.
Right. Now, there are also natural blood thinners like aspirin or bufferin or vitamin E or ginseng or ginkgo. And some of these drugs, aspirin is used in certain areas like people with a stent, etc., but not to treat a saddle PE or not a major PE. You wouldn't use any of those drugs. Even though they have some use, like aspirin has use in someone with a stent, or aspirin has use in, as we talked last time, in knee and hip surgery, you wouldn't use any of those drugs for a saddle pulmonary embolism.
Not for a saddle. No, none of that.
Or any other pulmonary embolism.
Or any other pulmonary embolism, yeah, but saddle's really dangerous. So please stay on your medication. It's very important. Todd?
So why are some patients approved to take an occasional ibuprofen? We're not supposed to take anti-inflammatory. We read that all the time. Should we talk to our doctor? Why do some patients get away with it? Some others don't. Any thoughts on that?
Yeah, well, I mean, it depends on why you're taking the ibuprofen. If your hip is killing you and your back is killing you, and you really can't get around and your life is misery, and ibuprofen relieves it, it does increase the risk of bleeding in combination with Coumadin or a DOAC. But, sometimes you got to make compromises. And so I try to get away with maybe one a day, possibly, but you got to also consider the person's quality of life. And a lot of people have really bad arthritis or and really benefit from these drugs. So you got to, look at each case individually. But
It comes down to risk versus benefit a lot of the time, doesn't it?
it may almost double the dose of the risk of a bleed. But you just tell that person, listen, when you're taking a DOAC and this isn't a bad advice for someone who's just taken an anticoagulant in general. When you're walking down the stairs, hold on to the banister, okay? Don't wear shoes that don't fit you properly. Tie your shoes nice and tight. And don't try to retrieve objects from overhead compartments on poorly balanced chairs. So there's a number of things you can do. What you don't want, if a person gets a little bruising from the NSAID, so what? I mean, you don't want them to fall and hit their head. That's what you don't want. So you want to give them all these areas where you can avoid hitting your head.
So you'd like this. I preach this a lot because I'm getting older, and as we get older, not that it's not important for younger people, but I've been telling people to work on their grip, right? Be able to grab, be able to have that strength, be able to be reactive, so we can prevent slamming our head in the shower.
Well, an ounce of prevention,
Yeah. That's right. I mean, having a seat and a grab bar, to me, that's not an old person thing. Sorry, I'm gonna save my butt if I have to grab on for dear life. So
absolutely.
Yeah, good point, Sam. Thanks. Leslie.
Okay. How do doctors decide when to stop blood thinners?
Yeah, good question. So, well, let me put it. So duration of anticoagulation is the question you're asking me. Duration. Okay. So this is a big issue today. It's worth spending a few minutes on because it comes up all the time. So basically, it used to be that we divided things into an unprovoked clot, like someone brought up earlier that they were going to have to take it forever, an unprovoked clot, or somebody who has a persistent major risk factor like cancer, getting treatment, or an antiphospholipid antibody. These are people that have to be on indefinite anticoagulation. Okay, that's one extreme. Then there's the other extreme, the person who has a blood clot with a major temporary risk factor like trauma or surgery. That person only has a 1% risk of recurrence. After 3 months, they can stop. Now, if they had trauma or surgery and they're still in a wheelchair in 3 months, no. But, generally speaking, that's the other extreme. So then we have the nuances. So then we have people who have a temporary minor risk factor like air travel, automobile travel, immobilization, hormonal therapy. These people have about a 3% per year risk of recurrence. So these are people who after 3 to 6 months are viewed to be at what's called equipoise, which is a Latin word, which means equal, poise, weight, equal weight to either need further anticoagulation or not. And these are the people that you're going to sit down with. You're going to talk to them about how they feel about further anticoagulation, about maybe getting a D-dimer test, about getting another duplex scan, and to see. And this is the person where you might want to check a factor V Leiden or a prothrombin 202 if you think that's going to tilt you. You don't get that test when someone gets a clot because it doesn't change anything. But here, where you're thinking of stopping with a person with a minor temporary risk factor like air travel, auto travel, immobilization, hormones. And then you have the person with a minor persistent risk factor, like the person with family history, or the person with the 5 Leiden or the 20210A who gets a blood clot after 6 months. And then you want to decide, and that's another kind of personal soul-searching decision. So there's two situations where it's pretty clear cut, the person who's got an idiopathic clot or the person's got a persistent major risk factor, that's clear in one direction. The person with trauma and major surgery, that's clear cut in the other direction. But then you have there's nuanced situations with a minor temporary risk factor and the minor persistent risk factor. So that's a lot to say, but that's the answer to duration of anticoagulation. And the point I want to make here is that when you check for thrombophilia, like 5-Leiden, 202-108, that's the place to do it, not if a person comes in with a clot to see if they got a 5-Leiden or 202-108, because it's not going to matter whether they do or not. You're going to treat them the same either way.
Yeah, and I think that's important for people to remember. Great response.
So if you have it, how long are you going to have a DVT in your leg? And so you have it in the back of your calf, you had the Charlie horse symptoms, you got diagnosed with the DVT. How fast do they dissolve? How fast does your body break them down? Is there a time window? How long should people give it and expect to have some discomfort while that's going on?
Okay, so we just answered the question, how long you give it. It's basically depends on how they got it, etc. So how long is it going to last? The pain going to last? Yeah. I think it varies on how big the thing is and the location. But the pain usually doesn't last that long. The problem that lasts long is the damage to the valves and the swelling and the post-thrombotic syndrome, which occurs in a significant portion of people, particularly people that get clots above the knee. That's the thing that lasts long. The acute pain associated with a blood clot doesn't last very long, and that's going to get better really quickly. And the anticoagulants, particularly heparin, in other words, if a person's got a tremendous amount of pain with a clot, I'm probably going to admit them. And, a lot of patients can be treated as outpatients. You just give them DOAC. But if a person's got a lot of pain, I'm going to probably put them in the hospital, put them on IV heparin, because that's got a real anti-inflammatory response, and that's going to get rid of the pain really quickly. So people with an average amount of pain, I would say it'll last a couple of weeks at the most.
If the lung is scarred after a pulmonary embolism, can the scar produce discomfort? Far out?
If the scar is peripheral, and in other words, acutely it can, because if it's peripheral, it's going to cause the pleura to rub against the two sides of the pleura, the linings of the chest to rub against each other. So you might have some pain when you take a deep breath, but that's not going to last. That's going to get better. But you can have pain like that from a peripheral pulmonary embolism.
Okay. Interesting. Okay. I've had a bilateral pulmonary embolism. Is there a way to regain lung strength?
Okay, so I don't know how long ago this happened, but there's respiratory therapists, there's physical therapists, and absolutely. There's definitely ways of doing that. And I would basically see either a respiratory therapist, a physical therapist. They can tell you someone who specializes in this kind of thing. And absolutely, you can regain a lot of your ability. Now, I think if there's scarring in the lung, you may not recover 100% of it, but you certainly can get to a lot better position than you might be.
Yeah, I think this is a topic that NBCA definitely needs to address, is the role of a therapist, a respiratory therapist or a physical therapist, potentially helping, because the patient doesn't get a lot of information about this, and there are folks out there who might be able to help. I think one of the issues is insurance, and whether or not it's covered by insurance, unfortunately.
Well, I think if you got a pulmonary embolism, insurances, they don't like to skimp on stuff like that, because the person can die, and then if they like to try to delay diagnoses or things like that, or delay treatment of other things, but not for a pulmonary embolism. I don't think that's where they choose to use their tactics, which are so annoying to those of us dealing with insurance companies.
Yeah, I have to say that I did work with a physical therapist, and he was incredibly helpful for my recovery. So if you can find one who's knowledgeable, by all means, I highly, highly recommend it. So, okay. We could go on for hours. We have so many questions, and it's amazing how many questions there. And I wish this was for more than an hour, but I do want to be mindful of your time, Sam, as well. So Todd, I think a few more
Okay,
questions.
so
and then
so here we go. This is out of the question bank. Is there any known correlation between taking high doses of prednisone and the occurrence of DVT? I was on a 2-week course of prednisone and developed a clot, my first and only, as soon as I stopped it with no taper.
Yeah, I think there is a correlation. Sometimes a little hard to say because people take high dose prednisone for inflammatory diseases, and inflammatory diseases can cause clots too. So sometimes a little tough to sort it out, but I believe that prednisone can do it, and I think that that is it's not the most well-known side effect of prednisone, but I believe that it is a side effect. It's just that it can get confounded with the treatment, with the disease that's being used to treat.
Sure. Okay.
Yeah, also super interesting.
Go ahead,
Okay,
Leslie.
we'll take another question from the Q&A. I've been on Eliquis for 6 years, 10 milligrams per day. Do I need to watch out for liver, kidneys, etc., from being on this anticoagulant? I'm a PE saddle survivor, so I will be on them forever. Anything that I should be aware of?
I don't think, I think that your doctor, I think your doctor should check you every so often and like with any other patient, monitor your kidneys and your liver. But those aren't the main side effects of these drugs. So I don't think you really, they're not known for liver toxicity or kidney toxicity. So I think that you just need to take it and, have them monitor these things periodically. Because the kidneys, particularly because they get excreted by the kidneys. So you want to, with Eliquis, if your kidney function gets below a certain level, if the creatinine goes over 1.5, there's 3 criteria that they may want to lower the dose, and that's one of them. The other is age over 80, and the other is if you weigh less than 60 kilograms. So if your creatinine goes over 1.5, you're going to need to lower your dose if you've got that plus one of those other 2 criteria, age over 80 or weight under 60 kilograms. So you've got to monitor that on Eliquis. Now with rivaroxaban, it doesn't change the dose. But I think it's a good idea to monitor the kidney function because these drugs are excreted by the kidneys, and it's good to know.
So just as a follow-up to that, because, patients are seen by different types of doctors. And in the instance where, let's say, you're not being treated by hematologists after the fact, you're actually seeing your PCP, those type of tests that need to be run or should be run, is that something that a PCP would know to do? Or should the patient say, hey, I want to get my kidney function tested? Or because what I worry about is that not everybody knows the test to do the way you do.
No, I think a PCP would know that stuff. Now, there's a few things a PCP might not know that I'd like to tell your audience here because I think it's important and we may save somebody's life by telling you this. So I'd like to do that. If you're taking Coumadin, warfarin, and you're supposed to run between 2 and 3, and the way your doctor's office is, they call you with your test results, and it may not be the doctor who calls you, it may be his nurse, or it might even be his secretary. So let's say your Coumadin, your INR is instead of 2 to 3, it's 6. So the secretary or the nurse or the assistant might say to you, because they're told to tell you this, are you having any bleeding? And you don't see any bleeding. You haven't been having any blood in your urine. You don't have any nosebleeds. You're not coughing up any blood. So you tell them, no, I'm not having any bleeding. Well, they may not ask you if you're having a headache. And headache is the most important sign of bleeding, but a patient may not recognize that as a sign of bleeding. So, and you might not get asked that question if you got a headache. So anytime you get a call, if you're on a DOAC or Coumadin from the doctor's office, from the nurse just checking up on you, giving you your test results, and they ask you, are you having any bleeding? You have to also, they may not ask you if you're having a headache. And if you're having a headache, an unusual headache or something, that you got to tell them, I'm having an unusual headache, because you might need to go to the emergency room and get a CT scan, and it could save your life if they pick that up early. And you might not get asked that question, which you should get asked if you're taking an anticoagulant. You may be asked that question by a secretary or an assistant or something. So I just wanted to point that out to you. I think that's important.
Oh, it's super important. Thank you for sharing that. I think you're right. That information probably did save some lives tonight. Okay, so Todd, I think maybe 2 more questions. And then
That's fine.
we'll move on to, I'm sorry that we won't be able to get to everybody's questions. This has been amazing, but do want to be mindful of time as always.
And we want to remind you, everybody, please talk to your doctor about this stuff. Your specific case needs to be discussed with your doctor, but we're so grateful to have Sam here to give us some excellent overall guidance on some of this stuff. Here's one that I think this came in right before the show. Actually, I wanted to make sure we got it in. I had a DVT PE in the right leg in 2017 due to birth control pills. I was on warfarin and then Eliquis. I wear compression hose to my knees. I have now been off Eliquis for 2 years and was just recently diagnosed with a superficial clot in my left leg. I'm now back on Eliquis. Will I be on blood thinners for the rest of my life? Why did this occur when I still wear compression every single day like I'm supposed to?
Okay, so what I would need to know is, you said the first clot was on the birth control pill, and I assume patient is not on any estrogens at this time. Once you have a clot, you're at increased risk for a second clot. And it's not just due to the damage of the clot. You can get that second clot in the other leg. Now, superficial clots can be just as bad as deep clots if they are within 3 centimeters of the saphenofemoral junction, or if they are longer than 5 centimeters in length. So I think you can't just downplay the superficial clot. Now, if it's a little tiny squiggle down around the ankle, that's one thing. But I doubt that that's what it is, because I don't think your doctor would have put you back on full dose anticoagulation. This is your second clot. And I will bet that it was probably at least 5 centimeters in size, or fairly close to the saphenofemoral junction, or the lesser saphenous vein and the popliteal. And I think you've got to be treated indefinitely, but that doesn't mean forever. Nothing means forever. We're always discovering new things. But I think that I would not just say this superficial clot is something to be dismissed. I think that, and I don't think your doctor does either. That's why he put you back on full dose anticoagulation.
Mm-hmm. Mm-hmm. Okay, thank you, Sam.
Okay, I take 2.5 Eliquis twice a day, but not always at the same time. Does the time matter?
Well, you want it to be close, because otherwise the levels are going to bounce around a little bit. So you want them to be relatively close. They don't have to be on a stopwatch or something like that. They don't. I mean, some people, if it's a minute late, they get upset. And I've gotten phone calls. I did this 5 minutes late, and I say, no, listen, give yourself a break. But I wouldn't just do it any time. I would, have it set out in some way that you have a system where you take it relatively close to the same time each day, so you have an even level. That's one of the reasons why Eliquis may be associated in some studies with lower bleeding because you have liver peak levels with this drug and it's a little more even. So I think you want to do that. You want to make sure that you keep it even.
This is amazing. I have more questions to ask.
Gotta have,
John,
come
you
on,
have one more that you want to go for it.
I really want to ask this one.
Go for it.
Let's just squeeze it in. So if you are already on a blood thinner at a therapeutic level and then get diagnosed with cancer, does it change your treatment or bridging before and after procedures?
So it doesn't change your treatment. And as far as bridging is concerned, it depends on the procedure. In other words, is it a low-risk procedure or a high-risk procedure? But if you're on a DOAC, and there's no reason you shouldn't be on a DOAC because they do just as well in cancer patients that need treatment. And these are studies that, have shown that Dr. Khurana, who's the president of our organization, his name is Khurana score over 2. It's been shown that, let's put it this way: these people have done just as well as with Coumadin. So I now the question is bridging. As far as bridging is concerned, I would bridge the patient like a person with didn't have cancer. It depends upon whether it's a high-risk procedure or a low-risk procedure. If it's a low-risk procedure, you stop the DOAC a day before. So if your surgery's on Thursday, your last dose is Tuesday. If your high-risk procedure, and it's on a Thursday, then your last dose is Monday, whether you got cancer or not.
Right. Okay. All right. Hey, I could go on for 2 or 3 more hours, but let's not.
No, I think we're definitely going to have to get you back. This has been incredible. Thank you. And we apologize that we weren't able to get to everybody's questions this evening, but we'll try to get Sam back at some point in time. I think we have some resources that we want to share with folks, or we want to make them aware of all the resources. We've talked about some of them tonight. So, please we have our new patient resource guide. Todd shares these in the groups. They're also available on our website. And I think the page is coming up now. There we go. New patient resource guide, which is absolutely fabulous. Our patient support group that Todd administers, also fabulous. We have a media library of all of our PEPs that you can see. And, they're recorded. Feel free to watch them. And we're always looking for feedback. So please don't be shy about going to info@stoptheclot.org and sharing your views on all of this. We did have a lot of new patients on tonight, and I think we need to talk about or think about how we help those folks that are kind of the 0 to 30 in particular days that have just been diagnosed. But by all means, take that new patient guide. It's full of wonderful information.
I could have used these PEP talks like 7, 8 years ago.
Yeah, you and me both.
Easy.
You and me both. I would have loved to have had that new patient guide. Sam, thank you. We appreciate you.
Thank you.
Hope to see you back soon. And everybody have a great night.
Okay.
Bye-bye.
Bye-bye.